Evil Dead. Toolkit for high-risk proliferative diabetic retinopathy. High-risk proliferative diabetic retinopathy is largely a surgical disease, and vitrectomy should be the mainstay in managing this entity. The role and timing of ancillary treatments, such as panretinal photocoagulation and anti-VEGF injections, should be customized on a case-to-case basis. Following a step-ladder approach may not be appropriate. Scenario 1. When PRP equals nail in the coffin. A 65-year-old patient with poorly controlled diabetes presents with PDR, characterized by extensive fibrovascular networks, extending from the disc and along the arcade. Our advice was for better metabolic control, close follow-up, and a subsequent surgery. However, the patient underwent 3 sessions of PRP laser elsewhere, resulting in tractional retinal detachment (TRD) progression, and presented to us again with sudden decrease of vision in both eyes. Each laser shot causes contraction of the fibrovascular membranes, making them more adherent to the underlying retina, resulting in crunch TRD, and subsequent surgery becoming complicated with poor prognosis. Compare the previous case with a treatment-naive diabetic, tractional retinal detachment case from another patient that underwent primary vitrectomy, without preoperative PRP. The complete removal of the membrane with forceps was possible with a little risk of underlying retinal tear, avoiding segmentation, reducing the need for multiple instrument exchanges and complex bimanual maneuvers, making the surgery easier. Scenario 2. Pre-vitrectomy anti-VEGF injection. The Devil and the Deep Sea. A 60-year-old woman, with high-risk PDR and vitreous hemorrhage in both eyes, was planned for anti-VEGF injection followed by vitrectomy. The vitrectomy was planned 3 days post-injection, and much to our surprise, an intraoperatively marked fibrotic switch was noticed, revealing new fibrotic membranes. The membrane management and the overall surgery became more challenging than easier. It is prudent to schedule vitrectomy 24 hours after the injection, and not later, to avoid these complications. Scenario 3. An alternative approach to PVD induction. Taking the bull by its horns. A 55-year-old diabetic patient presented with TRD in one eye and PDR in the other. The vitrectomy was planned without any prior anti-VEGF injection. In these cases, it is crucial to fully detach the posterior hyaloid as much and as safely possible to ensure long-term success. Inducing PVD with high suction in the attached retina in periphery, and extending it posteriorly to the fibrovascular membrane edges is a safe technique, minimizing the risk of retinal tears. This approach was successfully applied in a similar case, simplifying the overall surgical experience to the surgeon. Scenario 4. Divide and conquer. A 45-year-old diabetic with TRD in both eyes received an anti-VEGF injection before surgery. For extensive anterior membranes, relieving all anterior vitreous traction is essential before membrane removal. Using a 25-gauge spatula to create space between the membrane and retina, followed by membrane division with a cutter, facilitates easier bimanual surgery of smaller membranes compared to en-bloc dissection. This technique significantly reduces the risk of iatrogenic retinal damage. Scenario 5. A VT in time. A diabetic patient with lasered PDR, vitreous hemorrhage, and diabetic macular edema was presented to our clinic. The patient had previously been advised to undergo intravitreal injections elsewhere. A vitrectomy was performed, including PVD induction and ILM peeling, resulting in excellent long-term visual outcomes. Vitrectomy is also cost-effective compared to multiple intravitreal injections over the years. High-risk PDR would do better with early vitrectomy. Hence, simpler surgery and a better visual prognosis. A happy patient and a happier surgeon.